Papers are published, several studies are there which classify knees in normal knees into various alignment. So these are different people who are having the normal alignment and their knees are different, they are not deformed. So when this classification comes as a coronal plane alignment classifications, so in this coronal plane alignment of knee, normal alignment can be divided into varus, neutral and valgus knees, and joint line obliquity is also considered to divide them into apex distal, neutral and apex proximal. When this classification comes up, they study in a normal population, also in a deformity population, and they come up with this that population is having constitutional varus and constitutional valgus alignment, and if we correct all of these varus and valgus alignment into neutral alignment, there may be, that is the cause why we are having problem with the mechanical alignment things. So personalized orthoplasty concept is just new to us, and still it is not considered in among the all practitioner, where we are recreating the patient's constitutional alignment. The native alignment is achieved through this personalized concept. So why we need this personalized arthroplasty concept? Because after doing so many replacement, still patients are not happy, and that score is about 20 to 30%. As paper has suggested that 30% implant are planted in a wrong way. So these all papers, these all studies, they have come up with this idea that if we place more towards the native alignment, then mainly we are able to achieve more satisfaction in the patient's aspect. So poor functional outcome are the main reason because of which this has come up. Then in a personalized alignment, we cannot go directly with all these. We have to recreate this native joint line. This joint line obliquity is basic criteria in achieving all these personalized arthroplasty. So what we are doing in mechanical alignment, we are recreating the mechanical axis. 0 degree is our aim. Rectangular gap we want to achieve, and to achieve those rectangular gap, we are cutting perpendicular to the mechanical axis in distal tibia and distal femur and proximal tibia, and flexion gap is adjusted according to the bony landmark like transepicondylar axis. So here our aim is to balance all the knees into CPEC 5 classification. So mechanical alignment are very popular because of the ease of execution. There are reduced shear stresses. The failure of implant is also very less. Induced medial soft tightness, which is a natural tightness of many of the pupil, but is altered the femoral joint line obliquity, and they convert all the CPEC classification into the CPEC 5. So in mechanical alignment, these challenges are come up. So hence the kinematic alignment and other alignment has come up. Before that, I just want to highlight the anatomical alignment, where everything was placed in 2 to 3 degree of tibial varus, considering the varus as a normal thing, but it has a high failure rate. So that's why anatomical alignment is no longer practiced, and 1985 to 2006 is the era of mechanical alignment. Kinematic alignment, we are cutting exactly the defect only. We are just cutting for the replacing it with implant. Distal femoral cut, tibial cut, and the posterior femoral cut, all are just to match the thickness of the implant, considering the loss of the cartilage and the bone. So kinematic alignment principle is based on 3 axes. Axis for the rotation of tibia over the femur in flexion extension, axis where the patella is rotating the anterior surface of the femur, and longitudinal axis where the tibia, whereas tibia rotate over the femur. In the kinematic alignment, we measure the gaps also. We measure the cut, and we try to mimic as much as we plan. Considering the loss from the saw, we have measured during the time of the surgery also. We keep on taking the measurement, and then we perform this kinematic alignment of the surgery. So kinematic alignment is good if we restrict it to a particular framework, and that's how the restricted kinematic alignment principle comes into the picture, where we restrict it within a plus minus 3 degree of HK, 5 degree of varus to 4 degree of valgus. We are considering as a good criteria. So here, when we see the restricted kinematic alignment, there is a Manipal protocol. We have created a safe joint femur and tibia. We are cutting in a plus minus 5 degrees of HK, arithmetic HK plus minus 3 degree that we can consider. If arithmetic HK is less than 3 degree, we can directly go with the principle of classical kinematic alignment, where only the cut is replaced to replace the bone, replace the implant. And if it is more than 3 degree of varus, so in a varus site, we try to modify the LDFA first and then the MPTA, and in the valgus knee, we try to modify the MPTA. But we try to stay in the safe zone as much as possible. Then comes the concept of inverse kinematic alignment. Inverse because we, first of all, in here we make the cut over the tibia, and we match the native joint line. Once we match the native joint line, then we try to balance the knee, and as per the knee balance, we try to do the adjustment over the bony cut over the distal lateral resection and posterior lateral resection. So it is a technological assisted tibia cut parallel to the MPTA, and then later on adjustment is made over the lateral distal and posterior lateral femur. So in this inverse kinematic alignment, both varus and valgus, we take the restricted framework, 7 degree of varus to 3 degree of valgus, and try it in the tibial cut as equal medial and laterals, creating a native joint line, and then as per the flow, then we can go for the kinematic alignment. So functional kinematic, functional is alignment where we incorporate the balance into the kinematic alignment thing. We don't go for only the bony cut thing. So functional alignment, we can have a mechanical start point, or we have a kinematic start point, and after those start point we go for the. So in functional alignment, this is a picture of once we start with kinematic start point, then we can see there are equal cuts over the every part, and then after measuring this, we measure the laxity, and as per the laxity we will modify the cuts. So these are the kinematic start point, and same for the mechanical start point. So in a summary, I just summarize them that kinematic alignment is unrestricted. Once we restrict them, we come up with the concept of restricted kinematic, inverse, and functional kinematic. And the purpose of those things in a kinematic is starting with a native laxity that we are preserving, but then to preserve the balance knee that we are achieving in a inverse and functional alignment knee. Adjustment is made over the tibia in the kinematic and the restricted kinematic, whereas inverse is, that's why it is inverse, that we are making adjustment onto the femur side. Functional alignment, both femur and tibia we consider. Ultimate result is a happy patient, and that. Thank you.
Great.